Hello, hello, hello. Happy Friday. Oh my gosh. Ambish, we're in trouble. We're in trouble, my friend. Happy Friday is what I said, but no, it's Thursday, y'all. Um, Forgive me. Actually, I'm a little bit discombobulated. I had one of those unbelievably busy shifts in the emergency room yesterday where I actually did not eat the whole time, which thankfully is not a problem. I can more than make it up with inhaling food afterwards, but I'm still recovering from the constant stimulation and thinking yesterday. But I have my green tea and my VMR family. And today I was actually kind of laughing that I would have to introduce VJ again. I'll just tell you, VJ is back. We are so excited for his case today, and I'm very grateful for his many cases. He's established himself as a legendary case presenter, and hopefully, if I get my way, much more. But we'll save that for another conversation in a future time, VJ. What is new is that it is Umbish's first time discussing on this Thursday platform. And as is customary, as I mentioned before, we somehow make it feel like celebrating somebody's accomplishments in CP solvers is by having them be the most vulnerable they can be by discussing a case. But I also think Umbish needs no introduction. And it's crazy that that's true because it's despite being a full-time mom and being in a time zone that strongly conflicts with all these VMRs and in the middle of math season, she's managed to make such an impact on the inside of CP solvers. I think most publicly, you've probably seen her facilitate and anchor many teaching point recap VMRs on Tuesdays. But I will tell you, there's much more coming your way from Umbish publicly. Congrats on such a outstanding impact within CP solvers, and people really love your warm energy, your passion for medicine, and I'm excited for that to be on display today. I'll pass the mic to you to say hello, and then we'll divide and conquer for the rest of the hour.
Good morning, everyone, and thank you, Rabih, for such a lovely introduction. I think you've said everything that there's to say about me. And I'm really grateful for this opportunity. It's definitely the celebration. As vulnerable as I'm going to be in this space, I think this is the safest space to be. And I'm excited because this is a no judgment zone, and I have my entire CP Solvers family and a few other friends who are going to back me up and cheer for me. And I'm excited that it's a Vijay case. And all I'm going to say is that I'm heavily biased at the fact that it's not me, Turner. So I'm putting it at the bottom of my differential.
Amish, you've done your homework. I love it. Amazing. All right. Well, thanks in advance for Tansu for scribing a VJ case. It's going to be tricky, and to Anmol and Kushal for tag teaming the teaching points. All right, y'all, let's do this. Let's rock and roll.
So I'll start with the first aliquot. A 24-year-old college student presenting with a progressive shortness of breath since 1 year.
So, Ambish, as we talked about behind the scenes, there's no way you can come to a conclusion from this space. But I'm curious, if you had just heard shortness of breath, what might your thoughts have been just hearing those three words, shortness of breath? What crosses your mind if that's all you're working with?
So in the ER, if that is all I know that the patient is coming in with shortness of breath, I'm immediately going to, think about any life-threatening associations with shortness of breath. Let's say pulmonary embolism would be on the top of my, differentials, and then things like acute coronary syndrome. So those would be the first things that I would want to take care of, and then I would want to move on to more benign etiologies that would be associated with shortness of breath.
Yeah, superb. Not only are you incorporating morbidity, I think you're also incorporating base rate, which is it's telling that the two examples you came up with are ACS and PE, because of the morbid ones, they are common. There are super rare conditions that are equally deadly, like aortic dissection, but often when you're thinking of shortness of breath, you realize that there's both morbidity and, unfortunately, prevalence. That's superb. Now picture this. Okay, so you're there. You see that based on somebody handing you a sheet, or maybe there's an ER triage board that's very common in ERs in the United States. You see shortness of breath. You have no idea except the patient's name. And then I want you to practice this real life. You walk in the room and you suddenly realize that this is a young person. It immediately strikes you. And then if you were to pause in that moment, what do you think you would be thinking in that moment? Now you have shortness of breath and now you have young, but that's it.
Yeah, so when it comes to young patients, it's very odd that a young patient is presenting with shortness of breath. In this case, it's progressive, but the picture that you're portraying is a little different, right? So immediately I will worry that this is a young patient, this is shortness of breath, and I would want to take care of anything very acute that would be time sensitive, right? So again, like I said, pulmonary embolism, acute coronary syndrome, and many a times young patients have history of substance abuse. There might be some form of history there that I would be really, really interested in. And I guess just doing rapid imaging and diagnostic modalities to kind of see what I can do immediately.
Superb. I agree with all that. And I also love to capture another theme that I think is happening in your subconscious mind. And so I'll ask you it in another way. If you were to walk in that room and you don't know the patient's age, and somebody were to make you guess, what do you think you would guess your average patient with shortness of breath? What do you think their average age is? If you take all ERs across all the world and you were to say, what is the average age of a patient with shortness of breath? What do you think?
I'd say middle-aged.
Agreed. Yeah, it's so unusual for you to have shortness of breath and bump into a 24-year-old person. But here's the interesting part, Ambish. What is happening is your differential diagnosis isn't changing. You're still saying, I have to think about PE, acute coronary syndrome, all those things. So it actually brings up a very complicated analysis to think of is what happens to the differential diagnosis of a patient who is short of breath yet is young? And unfortunately, the answer is nothing. Nothing changes about the differential diagnosis. Why? Because acute coronary syndrome can happen in a 24-year-old. It just would be for different reasons. Pulmonary embolism can happen in a 24-year-old. It would just be for different reasons. Anemia can happen in a 24-year-old. Again, it would be for different reasons. So I think that the base rate of shortness of breath in a 24-year-old is exceedingly rare compared to older adults. However, unfortunately, because of the rarity of that presentation, it filters for much more morbidity. If you think of the number of cases of shortness of breath in older adults that have a temporary or maybe a less than severe condition like pneumonia or COPD, not acutely life-threatening, but walking out of this scenario and realizing that unfortunately it took 22 or 23 years of life for this person to develop this problem, as opposed to maybe 50 or 60 years of life for most people to develop this problem. You realize that you're in an unfortunate situation. Most of us let our guard down when we hear a young person with thoracic symptoms. We let our guard down because we know that it's so unusual for a young person to have thoracic problems. But if you are one of those unlucky people who is young and is developing a thoracic problem, you have now singled yourself out to be much more serious than the average older adult with a serious problem. So if you were to rate it on a scale, the average 24-year-old is here in benign world. The average 60-year-old here is accumulating morbidity. But the 24-year-old who shows up to the ER with shortness of breath is probably a little bit more morbid than the average 24-year-old. And it's really cool that in your subconscious mind, you're making that point. But you already latched on to one other really important aspect, which is that it's progressive for a year. So now if you're finally allowed to use all the data that you have, how are you incorporating that really interesting twist that it's actually been going on for quite some time?
So because it's progressive, that does worry me a little less. And I would like to clarify here, if possible, Vijay, is this a male or a female that we're dealing with? If you want to share it now.
I don't know.
It's a female.
Okay. Yeah, well, that changes my thought process completely because in females, many a times there's heavy menstrual bleeding around this age group, which can lead to anemia, which can then somehow be correlated with this kind of a presentation. So definitely in a female, heavy menstrual bleeding, history of any anemia is something that would be on the top of my list of differentials. And then it being progressive kind of rules out the most acute etiologies like a tension pneumothorax or a spontaneous pneumothorax or a tamponade or acute coronary syndrome. So the progressiveness and the chronicity of the symptom development then makes me wonder, if there's any associations, if there are any other links that I can form based off of the history of the presenting illness. So that does worry me less and opens up the door to many, many, many broader differentials.
Yeah, I completely agree with you. I think that whenever the time course is subacute to progressive, I think often you have much more time in the moment to figure out what it is. And you're worried that the patient is going to suffer serious consequences in the next minute or hour is very low. However, in contrast to hyperacute diseases, your ability to cure this problem is markedly less than a hyperacute syndrome. So if you take pneumonia, for example, a few days, and you can make the patient better in a few days, but there's a risk they might die from sepsis. If you take COPD, for example, the probability of a patient who's coming in with 1 year of COPD symptoms to die on you in the next hour is very low, but your probability to cure them is much, much lower. So you're picking up on a really important point. Progressive disease usually means less acute morbidity, but often comes with more chronic cumulative morbidity. I think it's going to be interesting to study the rest of the HPI. And I think I'll share with you a framework that we should try to use to help us get to the bottom of this, which is this shortness of breath loud or is it quiet? And let me explain what I mean. Fundamentally, we're trying to figure out if there are prominent accompanying features that help us figure out if the shortness of breath, what the shortness of breath is. So if the shortness of breath is coming with cough, with wheezing, with a lot of noise, it's very likely to be pulmonary in origin. If the shortness of breath is quiet and isolated and comes with not much else, then it's probably much deeper than the lungs. Maybe as deep as the heart, but also, as you point out, maybe as deep as the blood. So the more quiet and the more isolated the shortness of breath is, the more likely it is cardiovascular, including the blood. The more noisy it is, the more likely it is pulmonary in origin. So as we listen to this patient articulate her story, I think you probably should track how much noise, cough, wheezing is coming with it. And if it's not, you might have to go deeper than the lungs. So let's see, as we listen to Vijay's HPI, which way we might be leaning. All right, Vijay, mic to you, my friend.
The says the shortness of breath was progressive. So initially, the patient was able to walk about 2 flights of stairs. And currently now the patient is breathless on even walking 50 meters. A dry cough. And since 3 months, she has a bothersome fatigue, for which she is day-to-day active.
I think we lost Vijay. Let's give him a second. I think he might have dropped off. Let me see if I can find him. Yeah, I think he dropped off the Zoom room. All right. Maybe we can just chat about this. Ambish, what started to strike you with all this information?
So right now, the associated cough, and
I'm
then
really sorry.
Oh, he's
okay,
back.
he's back.
Yeah, let's get that full
I'm
data.
really sorry. Am I audible now?
Yeah, you sound much better now. Thank you, Vijay.
So bothersome fatigue. Okay. So there is no history of any seasonal variations or any wheeze or any hemoptysis or any chest tightness. Coming to the review of systems, it was negative for any chest pain or syncope. or lightheadedness. There is no history of any headaches. There's no history of any joint pains, fevers, weight loss, no history of any Raynaud's skin thickening or muscle weakness that the patient noticed. Coming to the past medical history, the patient was treated for pulmonary tuberculosis in 2020 with 6 months of the regimen based on a clinico-radiological basis of cough and loss of weight. At that point of time, HRCT done revealed right upper lobe consolidation with drain bud nodules. The history is also, past medical history is also significant for atopic dermatitis in 6 years, for which patient is on regular medications for the same. Social history, the patient says she has pet birds and she feeds pigeons frequently. There's no significant exposures or drugs or toxins that the patient is exposed to. So this is the end of Aliquot 2.
So Amish, I think maybe we can apply that first, try to make progress. If you think this is more cardiac, pulmonary, or blood, what did this data do for you at that macroscopic level before we zoom in on more details? Are you more inclined to be heart, lungs, or blood? What do you think?
So with this history, I'm inclining more towards the pulmonary lung etiology, and especially with the past medical history of the TB. Many times TB you treat it, but it is still not treated. It's unresolved, or it could be a secondary reinfection. So that is quite common, and that could then present with a progressive, the way this person is presenting. And then, yeah, I'm going to incline towards pulmonary for now.
Agree with you. The shortness of breath sounds not the loudest, but it is coming with a cough. And though the cough can be from a mediastinal issue or a cardiac issue, I think that it really makes me want to listen to her lungs to see if there's pathologies there. But you're right, there was pathology there in the lungs, and now it's hard not to worry about pathology returning. I completely agree. So now that you're zooming in on the lungs, what kinds of hypotheses is your mind generating about what the lung problem might be?
So with the progressive nature of the symptoms, if I just ignore the history of infections, I'm thinking, sometimes bronchiectasis, that person is also prone to more infections, and it is a chronic, it's chronic in nature, presents with a lingering cough, and these people are prone to infections. I'm also thinking of asthma. It could have been undiagnosed. Asthma tends to be progressive, and this patient does have an accompanying cough as well. The history of birds makes me think of hypersensitivity pneumonitis, and interstitial lung diseases, which also tend to be progressive in nature. So those are on the top of my differentials so far. Another thing that I'm thinking, sometimes there could be some underlying, condition that could then also be sort of not making sense right now, but I'm just thinking in the back of my head, maybe there is some background chronic condition going on that is still not diagnosed.
I think that latter thought deserves a special emphasis, because if you look back at how the diagnosis of TB was made, it was made using base rate and a CT finding. So the patient had a chronic consolidation and an upper lobe consolidation in a TB endemic region. And so, of course, that suggests TB. But the one thing about TB is that unless you're dealing with multi-drug resistant disease, the vast majority of patients, if they adhere to RIPE therapy, will be cured of the disease. So recurrence despite appropriate treatment is highly unusual. So if we're invoking that this person has TB, we might invoke structural complications, i.e. damage that was already done from TB that you can't quite reverse, like a cavitary tuberculosis that now is super infected, or maybe even bronchiectasis, as you mentioned. But I agree with you. I think that the ground that we're standing on is shaky. It's shaky because the diagnosis of TB was presumptive. So it's hard to know, is this person suffering a disease independent of TB? Is this person suffering a complication of TB in a long-standing manner? Or is the TB a distractor and the patient had something else all along? And I think that we'll be able to make a lot of progress understanding what the problem is on exam. But I agree with you. I'm not, in my mind, locking this in as a patient with a history of pulmonary tuberculosis. In my mind, it's presumed pulmonary tuberculosis. And we might have to revisit the specific features that were used to help us synthesize this either unrelated diagnosis or a diagnosis as a complication of TB. Excellent job. All right, Vijay, please tell us more.
So coming to the examination, so I just enter, I see this patient. The patient has disproportionate fatigue. Apart from that, the BP was 110 by 70 millimeters of mercury. There is no orthostatic change. The pulse rate was 87 beats per minute. The saturation was 96% on room air. But after making the patient walk for about 50 meters, the saturation dropped to 84%. There was grade 3 clubbing noted in all upper limbs and lower limbs. And systemic examination, the pulmonary examination revealed fine crackles just in the infrascapular areas bilaterally. The other systems were normal. There was no loud second sound that was normal. There was no LVST or RVST that was present. Then coming to the preliminary investigations, the hemoglobin was 13.8. The total counts was 11,000. The platelet was 3.56. The sodium was 131. Potassium was 4. The LFTs were normal. Thyroid function tests were within normal limits. A total IG was done, which was normal, 15.7. The total creatine phosphokinase CPK was 78. HIV, HBCG, HCV was non-reactive. The HRCT done recently in February 2023. The report is as follows: ill-defined ground glass opacities in right lower zone with right lower lobe with mosaic attenuation. And the transthoracic echo was done at the same point of time, revealed mild tricuspid regurgitation, a moderate pulmonary artery hypertension. And the RV systolic pressure was 52 millimeters of mercury, and the LV function was normal. So I think I'll stop.
Vijay, very, very intriguing. Ambush, there's a lot of data that I think we just got all the way down to imaging modalities. I feel like it's probably a good idea to practice what your mental summary is of the patient so far. So I think that gets at, of all the data you just heard, what you feel is the most valuable. So if we kind of take a moment to like mentally summarize this patient and do a problem representation, what would yours be right now?
So we have a 24-year-old female with a past medical history significant for pulmonary TB in 2020 and atopic dermatitis diagnosed 6 years ago, presents to the ER with progressive shortness of breath for 1 year, and dyspnea on exertion with existing on exertion.
Awesome. And I love that. And what of these findings are you then incorporating in your found to have section of the problem representation?
Could you say that again?
Yeah, no. Of all the data you just got now, in terms of the data you've accumulated. So in your PR, you're like, this person who had these things is coming in with this thing and found to have A, B, and C. And the found to have section is meant to capture all the high yield data that you have subsequently obtained. So of all this exam and labs, what do you feel like is going to be the most helpful to you to get to the bottom of it? The echo, the labs, the CT, the clubbing, what do you think are you finding the most valuable?
So in terms of the physical exam, the most pertinent finding is definitely, again, localized towards the pulmonary region. I did hear you say clubbing, but you said you used this terminology. Could you say that again? What kind of clubbing was it?
There's a grading of clubbing, wherein it's grade 3 clubbing. Where,
okay, so
like it is very obvious and it is in all the digits.
So clubbing also is seen in certain etiologies, right? Conditions like bronchiectasis. So again, those were two pertinent things that I would want to focus my attention towards to narrow down my differentials. As for the labs, they seem pretty normal. It does not seem like this person has anemia. There is no elevation of WBC. So in fact, I'm ruling out infection. The patient, we do not have the temperature, but I'm assuming the patient was afebrile. The blood pressure, everything looks normal. So the pertinent finding in physical exam would be the two that I mentioned. As per the imaging, the GCOs are catching my attention. And again, those are then I'm going to narrow down my diagnosis based on the HRCT findings. I do not know how to correlate the HRCT findings with the echo as of now, but there's clearly tricuspid regurgitation going on. I do not know why, and that is causing pulmonary hypertension, which could be the reason for the coughing and the pressure symptoms that the patient is having. And then when the patient walks, the dropping of the saturation also makes me think of some, underlying condition, which could be due to the pulmonary hypertension. It could be due to the underlying condition that is still not diagnosed. Again, ILD being on the top of my differentials.
Yeah, excellent. I completely agree with you. I think that if you are analyzing this data systematically, as you said, the clubbing refers to a variety of different underlying processes, but is most tightly linked with chronic thoracic conditions. Lung and heart are the most chronic lung and heart disease are the most common culprits, but in some occasions you can get it as a result of abdominal issues like cirrhosis or thyroid issues. But here, I think if you say clubbing, you're like, this patient has shortness of breath and clubbing. I'm most worried about cardiopulmonary issues. But then she has crackles and hypoxemia with exertion, suggesting that the primary culprit is in fact her lungs. So all the exam tells you is that you should really, really worry about her lungs. And then the data put together with the high-res CT and echo is helping you understand what that lung disease might be. And so you have a combination of two findings. You have intraparenchymal pulmonary findings. Your high-res CT is showing something in your lungs. And you also have cardiac findings, but are all on the right side. So the most natural connection between pulmonary parenchymal findings and isolated findings on the right heart are purely mechanical consequences. Chronic pulmonary diseases, especially those that cause hypoxemia on exertion, will cause pulmonary vascular vasoconstriction, resulting in pulmonary hypertension. And guess what happens? What happens when you have high pulmonary pressures is you have dilation of the tricuspid annulus and subsequent tricuspid regurgitation. So if we were to summarize, we have a subacute progressive shortness of breath that the exam helps us localize to the lungs. And the specific lung pathology we'll dissect in a moment, but lung pathology often causes pulmonary artery hypertension, which causes tricuspid regurgitation. So if you're trying to solve this problem, you will ignore the tricuspid regurgitation and you will momentarily ignore the pulmonary hypertension and realize that the essence of this disease lives in the lungs and has caused consequences on the part of the heart that perfuses the lungs. And so if we study the GGOs and the mosaic pattern, I'm not going to ask you to interpret them because it's a very unfair question, because it's very, very nonspecific. However, there is a little bit of value in understanding what mosaic pattern means. Instead of spending time on dissecting what it represents, I'll tell you the three possible manifestations of what that means. A mosaic pattern may represent airway trapping. So essentially, when there is expiration and inhalation during the high-res CT in a dynamic CT, if there's trapping of air because of distal airway disease, you can see this finding. So bronchiolitis or distal airway obstruction is a great example of something that will cause mosaic pattern. Patchy vascular disease. So if your vessels are occluded or dysfunctional, that can cause mosaic pattern. Or you can have an infiltrative disease in the lung result in a mosaic pattern. So the GGOs are non-specific, but the mosaic pattern has diagnostic value, and its diagnostic value maps onto either distal airway obstruction, like bronchiolitis, pulmonary vascular disease, or an infiltrative disease affecting the lungs. I think that's the key schema to deploy in this case so far. And when you zoom in on those causes, airway issues, vascular issues, or infiltrative disease, you suddenly have to pause and question the natural connection that we would be making in this time. And Ambish, just to reiterate it, the natural connection is pulmonary disease causes pulmonary parenchymal disease causes pulmonary hypertension, causes tricuspid regurg. But that logic pans out if the mosaic pattern is from bronchial disease. And then there's bronchial disease causes pulmonary hypertension, causes tricuspid regurg. But what if the mosaic pattern is representing pulmonary vascular disease? Now, here's the high-level point. Pulmonary vascular disease, primary pulmonary hypertension, can sometimes extend into the small arteries in the lungs, making you think that you have pulmonary parenchymal disease causing pulmonary hypertension. But in fact, the things that you are seeing in the lungs are actually vascular diseases. So there's a trap here. That trap is to assume that common things are common: pulmonary parenchymal disease, pulmonary hypertension, tricuspid regurg. But this high-res CT being positive may not be telling us this person has intrinsic pulmonary parenchymal disease. It may be telling us that this person has pure pulmonary hypertension with CT findings that are misleading us. And those CT findings may suggest that the pulmonary arterial disease is extending into the lungs and is restricted to the blood vessels. But remember, there's a third pattern to the mosaic. There's a third possibility to mosaic pattern: airway disease, vascular disease, and infiltrative diseases. It's also very possible that this person has an infiltrative disease affecting both their pulmonary artery and their lungs. So, Ambish, we're in a very complicated space here. The progress that we would make if we had resources is to do a dynamic CT, inspiration and expiration. Because if you did a dynamic CT, that will help you figure out, is your mosaic pattern as a result of airway obstruction? Because if you can make the mosaic pattern worse by getting a dynamic CT with inspiration and expiration, if the mosaicism is worse, that tells you that you have a distal airway obstruction. If your mosaic pattern is not affected by a dynamic CT, then you conclude that it's probably pulmonary vascular or it is an infiltrative disease. So we're in a very, very complicated space. Not surprising given the case presenter. But I really want to take a moment because I think you represent everybody here, Ambition, that I'm making the assumption that these concepts are not bread and butter for you unless you've secretly done a radiology residency. So I'm curious what parts of that were unclear, what questions you have, because it's going to be key to the rest of the case, I think.
So that definitely was new knowledge for me. The mosaic pattern, definitely, I was ignoring it because it doesn't like make me think of anything. But you've basically, I'm just going to repeat what you said and see if I understood you. Yeah. So what I understand is you've defined the mosaic pattern into three categories: airway, vascular, and infiltrative, right? And you said that based off of the findings of a dynamic CT, we can then further categorize it. If we do see changes in that mosaic pattern, if it increases and worsens, we're going to think of some airway obstruction dystrophy, right? And then you said, if not, then we're going to think along the lines of a vascular or an infiltrative disease.
Absolutely superb. You're a sponge. Oh my gosh, it's kind of terrifying. Alrighty, way better than I ever was. Amazing job, Ambish. Alrighty, VJ, please tell us more. Oh, we lost VJ. I'm trying to look for him. I think he has a couple of screens going. Oh, I think you're muted, VJ. We'll just give him a second. I think he's having some connection issues.
Just give me 2 minutes. There's some
Yeah.
issue with my connection.
No problem at all. No problem at all. Um, Ambish, I think maybe we can just take a moment while VJ connects. Um, when you think of pulmonary hypertension in a young person, just to analyze that, um, what sort of like reflex thoughts do you have if you have a young person with pulmonary hypertension? What do you think?
So, off the top of my head, the first thing that I'm thinking of is primary cause of pulmonary hypertension. And I remember, I think from first day, the BMPR2 gene mutation. That is the first thing that I'm thinking of in a young patient, and
Excellent.
then secondary causes.
Superb. Yeah, genetic and idiopathic diseases are definitely the most common. And then when you think of secondary, what kinds of conditions come to your mind as secondary in a young person?
So, certain connective tissue diseases can lead to fibrosing conditions, can lead to pulmonary hypertension.
Yeah, exactly right. And I think that tells you why VJ was like, oh, the CK is normal, hinting at autoimmune myositis, and the patient has no arthritis or Raynaud's or whatnot. He's doing a very, very thorough and exhaustive review of connective tissue diseases. Yeah, I think that we probably would, in this case, would probably lean on a family history to help us figure out if that's in the background or not. But yeah, I think I see VJ back, so I'll pass the mic to you.
It says hostess disabled participant screen sharing.
Oh, I'm sorry. Um, the host is the host thought it was Friday today, so good luck to the host. There you are. I think you should be able to share the screen now. Yeah, it might be a little hard with the internet today, VJ, unfortunately. I love that he left us with mosaic pattern. Yeah, there you go. Okay, okay, we're good. It showed up now, VJ. All right. I think you're muted. Yeah, VJ, I think you're frozen again, unfortunately. I just love how he powered, like he is completely unfazed. I will show the CT no matter what.
Is the screen visible or is there some issue? Is it
Yeah.
playing?
Yeah, it's unfortunately very yeah, I think
Unstable.
it's very, very slow, I think, unfortunately, VJ.
Uh, I'm really sorry.
No, don't worry about it. Oh my gosh, don't apologize. Maybe you can tell us verbally, and then we'll see at the end if we can show the CT after you give us the data. How does that sound? Oh wait, no, it's working. Okay. All right. I think you played it now, VJ, but you're muted. You probably have to unmute so we can hear you describe it. Huh. Whoa. Wow. Oh my God. That is not a very pretty CT. I think the one on the left is prior and the one on the right is the most recent one, Ambish. And I now I think we're seeing the GGOs and the mosaic pattern at the bases. But the upper lobe was not normal either.
Was in
Oh, we can. Yeah, Vijay, I think you were muted earlier. Do you want to just describe your yeah, right?
yeah. So the first CT that was done was in February when the patient had tuberculosis. That was based on this CT that was done. And the second CT was when I saw this patient. Somehow I am having some issue with my connection. Maybe I'll describe the CT. And maybe I just want to highlight some points in the CT that actually gave us the diagnosis, that made us suspect a particular diagnosis. The second CT, we are seeing diffuse mosaic attenuation and diffuse GGOs that are there with some reticulations and a right upper lobe cavity. And there is no particular apicobasal gradient. And there is features suggestive of an NSIP pattern. So there is mosaic attenuation, reticulation, traction bronchiectasis with no apicobasal gradient, and features are suggestive of NSIP pattern. Also, there is a CTPA that was done. There was no any feature suggestive of a chronic thromboembolic pulmonary hypertension features that was seen. We also subsequently did a bubble echo which revealed no intra or extra cardiac shunt. And an ANA, ENA, and RA factor and anti-CCP was negative. So after this, I have further one aliquot where few tests were done and we had the final diagnosis. So if there is any particular investigation that you could request for, you can go for it.
Awesome. Thank you so much, Vijay. Very, very striking CT. It was really, really unfortunate. Yeah, Ambish, this case is definitely very tricky and very unusual. I'm curious what thoughts are crossing your mind.
So now I'm still thinking about the same mosaic pattern and discussion that we earlier had. And if I could now, anything new that I saw, I did see fibrosing. So there was a lot of fibrosis, which is why we saw the traction bronchiectasis. So there's definitely some chronic fibrosing interstitial parenchymal lung disease that I'm thinking of. I'm not thinking of vascular phenomena based on the CT findings. And again, I'm not good with these detailed, CTs. I did not understand a lot of the things that Vijay said, but this is where I'm at. The GGOs are there, the mosaic pattern is there, and then the fibrosis and all of that. And I'm not sure if moving forwards, would we want to do a lung biopsy to reach a definitive diagnosis? And that's where I'm at.
Excellent question. Yeah, I think that the conclusion you can come with is like that there is extensive pulmonary parenchymal disease, GGOs, traction bronchiectasis, reticulations, and I think that the pulmonary disease is so extensive that it's in a specific pattern, NSIP, non-specific interstitial pneumonitis. And if you don't really need to know much about NSIP except to know that there can be primary NSIP, but secondary NSIP is often secondary to a wide variety of autoimmune conditions. So here we are thinking pulmonary hypertension without a family history of genetic diseases, and you said immediately autoimmune. And here you are thinking NSIP, which is again strongly associated with autoimmune disease. But as we heard from Vijay, the ANA is negative, the rheumatoid factor is negative, and the CCP is negative. So I think it really it's a tricky situation to be in. I think a lung biopsy is very, very wise here. But as a general formulation, just to share with you, and then we can analyze it, is whenever you're dealing with a chronic lung disease, the first step is to try to establish, is this a lung disease alone, or is this lung disease with another peripheral clue? So if Vijay told us this person has a malar rash and Raynaud's phenomenon, along with this lung disease, it would be a much easier problem to solve. So I think that's the kind of branch that we have now. The only thing that the only features that we have that are outside the lungs are cardiovascular complications, which can easily be mechanical in nature. So far, this disease appears to be isolated pulmonary disease. But the question is, can there be any subtle extra pulmonary involvement that we may not have picked up on so far? So if you kind of go through your checklist of autoimmune diseases, this is a tough one, so we'll have to do it together, honestly. If you go through a checklist of autoimmune diseases like inflammatory myositis and Sjogren's disease and scleroderma and lupus, are there any symptoms that you associated with those conditions that may not be readily apparent that you might have to ask on review of systems or investigate? What do you think?
I mean, there's so much that Vijay has given us that helped us rule out a lot of these. So I'm honestly not sure. But then there's no kidney involvement, and he did
Right.
not talk about any
Excellent.
creatinine, any kidney function tests that were done for this patient. That would be something I would want to know. Physical exam usually tells us a lot about the skin findings, but we did not have any.
Right.
Um,
Excellent.
yeah.
I really love that you looked for the sneaky glomerulonephritis findings, which were a clue to yesterday's case. I love that you realize that the ANA is an excellent test for many autoimmune disease, but here's a little bit of learning. It's only helpful for 3: lupus, mixed connective tissue disease, and scleroderma. All other autoimmune conditions are not reliably ANA positive. So could this person have a lupus, scleroderma, or mixed connective tissue disease? Highly unlikely. Could this person have rheumatoid arthritis? The answer is definitely not now. But could this person evolve to have RA? Yes, it's possible. There's increasing recognition that rheumatoid arthritis can ultimately develop in patients who have a pulmonary signature beforehand. However, those patients tend to have a CCP positivity early on and predicts the development of RA. What's more likely to completely sneak up on you as an isolated lung disease that is actually autoimmune in nature are the autoimmune myositis, which are reliably ANA negative, less than 50%. So despite the normal CK and despite the no lack of muscle involvement, many of the inflammatory myositis can cause isolated pulmonary disease either forever or with eventual progression to more prominent extrapulmonary clues. So it's very important in these patients to realize that the ANA is not sufficient as a screening test, nor is the CK. And a quote-unquote myositis panel is sent in these patients to zero in on that possibility. So just to summarize this very complex case and to outline our plan for the next aliquot, shortness of breath for a year, we were deciding if it's loud or quiet. We figured out it was very loud, a lot of coughing, a lot of lung stuff. We found the lung fingerprint of this disease, NSIP. NSIP is autoimmune disease until proven otherwise. The initial round of testing for autoimmunity is ANA-RF-CCP, which is great for 4 conditions: lupus, scleroderma, mixed connective tissue disease, and RA. A very important category of connective tissue disease that affects the lung that doesn't show up on that prelim screen is the inflammatory myositis. If, however, this disease is purely restricted to the lungs and does not have any extrapulmonary serological manifestation, then I think you might have to go back and wonder, does this person have any exposures that disproportionately affect the lung? Revisiting the pigeon and the birds. However, an NSIP pattern is not something that I associate with the kinds of diagnoses you would associate with exposure, like hypersensitivity pneumonitis. Any thoughts or questions about that? Anything you want to add before we get some more data from Vijay?
I'm just lost a little.
Yeah.
I just had a question.
Yeah.
I have a question regarding the myositis. Are you
Yeah.
referring to polymyositis and dermatomyositis? Is that why you want to do the Okay.
Exactly right. Yeah.
And the last part about how you said that you don't feel like there's an association between the bird hypersensitivity pneumonitis. I did not understand that part. How are you saying that that's not on your list?
Great question. Yeah, there's a less compatibility with hypersensitivity pneumonitis and the CT findings that Vijay's showed us. Hypersensitivity pneumonitis is a dynamic disease in terms of its radiological manifestations, with patients essentially initially presenting with micronodules and ground glass opacities along with mosaic attenuation. And then they progress in a manner that maintains what Vijay was saying, an apical basal gradient. The disease migrates apically to basally, or actually I forget, basally to apically or apically to basally. One way or the other, it moves. And in more chronic forms, mimics idiopathic pulmonary fibrosis or IPF. But the buzzwords you want to associate with hypersensitivity pneumonitis are micronodules, ground glass opacities, airway trapping from mosaic hyperattenuation, and then progression to an IPF type pattern. This patient is also fairly young. It's unusual for somebody to have that much exposure at 24 to develop HP. But the short answer is NSIP, the non-specific interstitial pneumonitis, is less compatible with HP in my mind, but I would revisit that possibility and explore that and learn more about it should the autoimmune hypothesis not pan out. But I think NSIP, think autoimmune, and recognize that ANA and RF are not a great test for a very common scenario where myositis are disproportionately affecting the lung first. All right, Vijay, please tell us more. Gosh, we lost him again. Oh no. Oh, there you
Is
go.
it
Yes, yeah, you're on. Thank you.
So there is one particular finding that took us away, even though all this workup was negative. In the CT, I just wanted to show somehow my connection. The laptop doesn't seem to have some issue. So in the CT, if you could remember, along the fissure, there's a consolidation-like pattern that was seen, and it was around the airways. So there is this component of NSIP with some component of an organizing pneumonia-like pattern, wherein you have a dense consolidation, and there is consolidation surrounding the fibrotic airway. So a combination of an fibrotic NSIP and an organizing pneumonia, especially a fibrotic organization pneumonia, made us bring the possibility of an inflammatory idiopathic myositis. So in this patient, the PL12 antibody was strongly positive, and it was also positive for MI2 alpha. So the final diagnosis we made was a myositis ILD syndrome. So the patient was started on steroids with MMF, and the patient is on regular follow-up.
Vijay, I'm a little worried that because of your connection, people did not see the amazing teaching point you just made. So I'm going to share it with folks. I'm not sure if you can hear this, Vijay. Vijay taught us that actually one thing that he didn't get a chance to emphasize was this pattern on CT, an NSIP OP pattern, overlap pattern. And the truth is that there's so much alphabet soup to remember here. But I'm trying to find you a good CT. So the NSIP, actually, none of these are very good, unfortunately. I'll just leave it at like bare associations, and then maybe Vijay can emphasize it later. NSIP, autoimmune disease. OP, many different things. NSIP and OP on the same CT is basically inflammatory myositis until proven otherwise. I hope that was a fair summary of your excellent teaching, Vijay. Ambish, you were like, what is this whole discussing clinical reasoning cases all about? That was a very, very tough case. And I'll just want to summarize the final diagnosis. This is an inflammatory myositis without any sign of inflammation anywhere and no muscle involvement. Just to emphasize that that's the conclusion that we've come to. But I'm curious, what are you thinking? What are your thoughts?
Um, I'm again in awe of this diagnosis. I've never seen something like this before. We couldn't see the CT very well, but there was a lot happening, and I could not have diagnosed. I even thought about myositis until Rabi mentioned, because there is nothing for me to sort of align my thought process towards that end, except that I was thinking of autoimmunity and a fibrosing lung condition. So I'm just shocked and amazed at the way these things present, completely contrary to what we see in textbooks. So thank you for enlightening me, both you and Vijay. I'm grateful for, just the learning that went on today. But I have to say, Ravi, I think you jinxed today's session by saying Happy Friday. This has never happened before.
No, I never have. um, Amish, I think that what these sessions are all about is actually to really illustrate that all of us are learning. All of us are. The images that I tried to show you of NSIP and OP overlap, I learned 2 weeks ago in a case conference that I was sitting in, and I was just like you. I'm like, what is this person talking about? I've never heard of this before, and that triggered a lot of reading and the reflection. And it's timely 2 weeks later that we get a case that reiterates that learning. And so all I can say is actually that what you did so well is to be very, very honest and authentic about how far you can take this case, and to be very open about where you are going to learn and grow. And I think that's really what this is about. There's nobody who isn't here now who didn't learn something, including myself. And so I really admire and respect that a lot. And I can only imagine what happens to somebody if their career is filled with, here's what I know and here's what I'm going to learn every single time. And I really appreciate you modeling that today. And I'll just emphasize that I'll end by this. The story of autoimmune diseases is a story that we've been told in one order, but can show up in reverse combinations. And I think we're learning more and more and more about that. But I see that Vijay's got the screen going. So Vijay, I'll pass the mic to you to teach us this really cool CT pattern, since the connection seems to be better.
Yeah. So I think there is a small lag between the video and the Zoom that is there, but I think this should be okay. So this was the CT and this is the CT that was done. You're seeing a lot of reticulations. This is the part of, yeah. So this was exactly the point where the patient had a tuberculosis. The same side, there's a cavity that is formed. But apart from that, you're seeing a lot of reticulations. So what we call these as a small, small cyst-like lesions. So it is there throughout the lung. So these are the reticulations that are seen. And so there's a complete haziness that is there. Okay, I think I lost.
My gosh, Vijay, your efforts are unreal. I really, really appreciate you trying to power through and show us the CT. I think I'll just email you afterwards and maybe get the video from you, and we'll start tomorrow's session by showing your CT, because I think it's really, really cool. But for those of you who are inspired to learn more and more about this today, just Google or look at NSIP and OP overlap CTs. Just that'll show you representative images of what Vijay is looking for. All right, y'all, we're out of time. I'm sorry for the delay. I think we learned a lot, but I'm excited for the combo dream team of Kushal and Anmol to tag team the teaching.
Hey, it was an amazing case, and as usual, Vijay brought in mind-blowing diagnosis. And the main important thing which I learned was, when there's a person who's presenting with shortness of breath, see if it's acute onset or chronic, as well as who's presenting with the shortness of breath, whether it's like a woman or a man or a young age or old age. and if they had a pre-existing condition or is it just a new onset. And that's going to help with further diagnosing and characterizing whether it's from the airway, and think of asthma or COPD, or if it's parenchymal, whether it's ILD, or if it's like also vascular cause like PE. And the other thing which I did learn was about orthodeoxia, which is like the positional change in shortness of breath, which can happen with hepatopulmonary syndrome. And just last one more point before I hand over the mic to Anmol is whether the patient is having a history of tuberculosis is there, then just think whether it is due to tuberculosis, whether it's a recurrence or if it's a complication, or if the presenting complaint is independent of the history of tuberculosis itself.
Amazing case, and every teaching point is very important for me. First thing I learned is that clubbing is tightly linked with chronic thoracic problems, which could be from heart or lungs, but it is also associated with abdominal issues like cirrhosis and thyroid issues. And in this case, we are focusing more over lungs, as we see from the examination. And if there is like some lung problem, and because of which there's a constriction of the pulmonary vasculature, it can lead to the pulmonary artery hypertension. And how that pulmonary artery hypertension causes tricuspid regurgitation, we learned by this mechanism. We can see that this patient had tricuspid regurgitation, and that we ignored that. Why? Because we knew that this patient had pulmonary hypertension, and which actually causes dilation of tricuspid annulus. Therefore, tricuspid regurgitation occurs in these patients. And then we learned the most important point about the mosaic pattern. I had no idea about it, but we learned that it can be due to three main causes. It could be airway trapping because of distal airway disease or bronchiolitis. Or second, it could be pulmonary vascular disease. And third, it could be infiltrative disease affecting the lungs. So how do we differentiate what is the possible cause? We see a mosaic pattern. How can we differentiate? We can do a dynamic CT. That is when the patient breathes in, inhales, and when the patient exhales. We can do a dynamic CT. And if the CT finding changes, that is, if it's affected, then it is most likely a distal airway problem. And if the CD findings are not affected, then it is most likely a vascular or an infiltrative cause. And next, we learned about the NSIP, and which is non-specific interstitial pneumonitis. And we learned that it is an autoimmune disease until proven otherwise. Why? Because NSIP is causes are either primary or secondary. And primary, that is idiopathic, and secondary is either due to autoimmune conditions. The most important thing I learned was that ANA positivity is not reliable for every autoimmune condition. It is only reliable for SLE and mixed connective tissue disease and scleroderma. For other autoimmune conditions, we cannot just say that that we cannot diagnose autoimmune diseases based on ANA negativity. For example, the inflammatory myositis, ANA can be negative in those. And the autoimmune myositis, they can cause isolated pulmonary disease with the absence of myositis and other features. That's what we saw in this case. And NSIP, OP overlap pattern are actually inflammatory myositis until proven otherwise. So thank you so much for the amazing case and amazing teaching. Thank you so much.
Oh, absolutely amazing recap. Dynamic green team. That was really cool. Amish, a marvelous job taking this case very far and acknowledging that not many soon-to-be residents know the differential diagnosis of NSIP and OP overlap, and making that a point to learn and reflect on in the future. Vijay, if you're still here, amazing case. I'm so grateful for all the amazing pulmonary learning that you brought to us. It's endless, truly. And I can't wait to share your CT tomorrow. I'll send you an email for that. Hope to see you guys then, at least for VJ CT, if not for a really cool case. Enjoy the rest of your day. Bye.